in the African American community. I am not Munson Steed. Uh, graciously let the ladies lead today as we talk about Black women and wellness. So we're really excited about the show today. If you have any questions, put them in the chat, and we'll try to address them while we cover all of this great information. So first, I'm going to start off with Angela Ford. Angela, can you just share a little bit about yourself and why are you so passionate about Black women and wellness?
Sure. My background is in psychiatric social work. I worked for a number of years with women who had been sexually abused as children in counseling. Then went to the University of Pittsburgh, worked at the Graduate School of Public Health for about 22 years. Took an early retirement, decided to move to Maryland to be closer to my grandchildren, and thought I would take this small project on. And as it turns out, 8 years later, it's bigger and better, and I'm still there. I'm the Chief Program Officer for the Black Women's Health Imperative, and we're a national nonprofit here in DC and in Atlanta, 38 years old.
That's fantastic. Welcome, Angela. We're happy to have you today.
Thank you.
Dr. Gail McDonald, can you share a little bit about yourself and why you're so passionate about Black women's health and wellness?
Sure. Hi, everybody. I'm Gail McDonald. I actually am an OBGYN physician, and I've been practicing for the last 20 years in the New York region, as well as here in the Maryland region. I have been participating and working with community health from the time of graduation. I'm a proud Howard University graduate from the Mecca, and we do quite a bit of work on a regular basis on community affairs, doing health symposiums and taking care of our community because we're paying attention and we want to make sure that our women are well and aware of what their health issues can be and what we don't want them to be.
I love that. I love that. And finally, we have Denise Pines, all the way from Los Angeles, California. Can you share a little bit about yourself and why you're so passionate?
Yes. So I am the president of the Medical Board of California. I'm in my third term. I have been in the health space more from a media standpoint, producing health content for the last maybe almost 17 years, with a lot of focus on marginalized communities and the challenges that they have. I also, as a result of going into menopause, started an event called Wise Pause Lifestyle, which is a pro-aging health and education platform to empower and connect women to some of the most trusted and critical information during these midlife years. I also am the co-author of a report called Fem Aging 2020 Health and Tech Report that looks at the concerns and needs of women 40 to 65 as it relates to technology.
Well, that's great. We'll have to get into that a little bit more later. Well, welcome everyone. So we have a lot of ground to cover. So I'm going to start with Angela. And so Angela, we know that your organization deals with diabetes prevention. And I really even just like that terminology. I think, 10 or 15 years ago, we were talking about it after it was a foregone conclusion that you were diabetic. And so just the word diabetes prevention has resonates so much better, more positive, because that means there's something you can do to actively prevent diabetes. So I know we've made great strides, but what is working in the prevention space for diabetes? And, what can we do to continue to be better?
So like you said, the good news is that it is preventable. And you'd be surprised at how many people still don't think it is. And one of the things that's happened over the last few years since the research came out and determined that you could prevent type 2 diabetes if you were at risk for it. One of the things is that folks are more aware of it and aware of the fact that it can be prevented. And so now not everybody is assuming that just because my parent had it, I'm going to get it. There's more screenings. Folks are being screened for prediabetes. We actually encourage women to ask about it during their well woman visit. My doctor tells me that all doctors screen for it, but we see women all the time in our program that say they if they were screened, they weren't told about it. And so they weren't aware that what their numbers are even.
What are the
And
numbers? What are the numbers that are most important as it pertains to diabetes?
so the 5.7 to, I believe it's 6.4, the doctor can confirm that, is the pre-diabetes range. And so when we are enrolling women into our program, they're required to have a BMI of 25, either be diagnosed with pre-diabetes, have a history of gestational diabetes, or score a 5 on a risk test, or 5 or above on the risk test. And so, and folks are also surprised that you just really need to lose about 5% of your body weight and be physically active for at least 150 minutes per week to reduce your risk of type 2 diabetes.
So let's break that down. You said 5% of your total body weight. So
Yes.
If you are 200 pounds, it's 5% of 200 pounds.
Yes. And what that does is when folks hear that the 5% will make a difference, that's a big motivation to lose more. Right. So, during the first class, they set their goal weight. And most folks go beyond that because they realize, well, if I can do 5%, then I can do 10%, I can do 15%. So it's not quite as overwhelming as somebody saying you have to lose 100 pounds or 50 pounds. So the message really resonates with women.
That's fantastic. What are some of the improvements that could be made? So those are some of the wins, but where do you see a block where we could move a little bit further in diabetes prevention?
Well, again, the big deal, I think a lot of people don't know they have prediabetes. A lot of people don't know they have type 2 diabetes even. So I think the awareness, just continuing to get the awareness out there and making sure that the messaging is clear to the individuals who are most at risk for it, making diabetes prevention programs accessible in communities where folks can easily access either this program or some other resource that will help them learn how to make healthy lifestyle changes that will help them prevent the disease. And in fact, it's if you do make the lifestyle changes, the healthy lifestyle changes to prevent type 2 diabetes, you can also prevent all kinds of other chronic conditions as well. So just continuing to get that message out there and helping to increase more awareness and communicating with your healthcare provider about prediabetes and diabetes prevention
is key. That's a really good point. I also like the fact that your program is really creating community and having that community support and accountability to help promote, health and well-being. So it's just it doesn't just lie within you.
You're not in it on your own. Exactly. It's group-based. It's a year-long program. And right now we're able to offer it at no cost to individuals. And Medicare actually covers it for their members. But it's a year-long program. It's group-based. So you get all this support. You have your own tribe of support and you get a personal lifestyle coach.
Oh, that's good. Yeah. You have a website? We can put it in the chat.
Yes, bwhi.org/CYL2. And that CYL2 is actually our program name, Change Your Lifestyle, Change Your Life.
I like that. That's good. Now we're going to move into Dr. Gail. Hi, Dr. Gail. When we were talking earlier last week, I was telling you, I know a lot of women that their OB is their end all be all of doctors, right? And so, after talking to Angela, like more than likely, I'm sure you have patients coming to you and they're having these types of conversations around diabetes and things of that nature. But do you recommend that everyone have like a primary care physician?
Yeah, absolutely. There's quite a bit that we can do as obstetrician gynecologists, but we can do preliminary screening in order to follow any chronic illness, in order to follow any concerns that are medical. We need to pair them up with either a family practitioner or an internal medicine specialist.
That's good. And I always liken, because, it's difficult to find doctors that you vibe with that can relate to you. But in the same way that we'll shop around for the perfect hairstylist, we have to with our healthcare providers as well, and keep finding, keep going to them until we get one that gets it right. I wanted to have a chat with you because it's, I have noticed in communication with friends, reading articles in Black magazines about a condition called PCOS, and there is a little bit of a dotted line with diabetes as well. Could you share more about what PCOS is?
Absolutely. Yeah. PCOS actually stands for polycystic ovarian syndrome. And it's hitting our African American community quite hard, in terms of numbers of patients that actually come in with maybe not full diagnosis, but multiple symptoms of it. Polycystic ovarian syndrome, just like the name sounds, there's multiple cysts in the ovaries. But just knowing that isn't the only piece with polycystic ovarian syndrome. It comes with multiple issues. These are patients who are having issues with their menstrual cycle, having issues with weight gain, having issues with increased hair growth that can be in a male pattern. They are also having issues with fertility. So it really plays a strong role in multiple aspects of their life. When we work with those patients, we're working with cycle control, we're working with fertility concerns as a preconception counseling. We're also working with them for issues of aesthetics because they're concerned about the hair growth that is, plaguing them. They usually can get it on the face, and that can be very disconcerting because they gain some hyperpigmentation from that. We actually work with them to improve their weight because a lot of our patients with polycystic ovarian syndrome, not all, but many are overweight and they are hitting BMIs greater than 30. So as a result, we are working with weight control, and we're looking at something else. We're looking at their hormones. The testosterone levels in these patients tend to be higher because they're lacking an enzyme that is really important in the cycle of hormonal breakdown. So when we are trying to gain estrogens, these patients with polycystic ovaries, they actually have lower levels of estrogen and higher levels of testosterone. And that actually works against them when it comes towards fertility and when it comes towards metabolism. So a whole other piece, which kind of links us with diabetes and risk for type 2 diabetes, is that they get something called hyperinsulinemia. Hyperinsulinemia means that their insulin, their pancreas is secreting more insulin than they can control. And as a result, if you ever think of like the brain releasing these little Pac-Men that want to gain, they're a trigger, the insulin gets released from the pancreas and those little Pac-Men go a-running. So what they're really dealing with is that their insulin is releasing heavily. They're actually triggered because they want to eat more heavily, and they're actually gaining excessive weight because of the fact that they may be triggered to eat carbohydrates, and they're just eating the wrong things. So there's a whole dynamic with polycystic ovarian syndrome beyond just cycle control, fertility, but metabolism and metabolic syndrome where they're gaining weight, especially in the belly, and it's actually another cumbersome piece that we try to treat.
Wow. And so so you talked about fertility. So what about when you are perimenopausal or menopausal, can you still have PCOS?
You actually can, yes. Start thinking about our perimenopausal, menopausal group of women, these are women who, if they had PCOS in their younger years, they still may have PCOS or symptomatology associated with PCOS. So things like the elevated insulin levels could actually get worse around the time of menopause, and that could lead to further weight gain at that stage of menopause. They can be dealing with that testosterone level being elevated, and if it's not under control by that time when they're reaching menopause and perimenopause, those items can get elevated as well and get worse around that time period.
Wow. Okay. And so you said that the signs to look out for PCOS, irregular periods, you might have some male hair growth that could be on your face or on other places as well.
Excessive hair growth.
And are there any other symptoms that folks should be looking out for?
They look more so at those two particular symptoms and fertility, because we usually capture our ladies in their 20s when they're initially trying to cycle or they're trying to get pregnant. So that's usually the time period that we capture them. But there are radiographic studies that we use, imaging, in order to see the ovaries themselves. And so one of the pathognomonic signs of PCOS is going to be a sonogram that shows multiple follicles in the ovary. And those follicles actually take on this ring-like projection. It's like a ring of pearls. And those are there in the picture of the ovary, and they can be pretty diagnostic. That most of the time you'll see that with a polycystic ovarian syndrome patient as well. But they're triggered to do the imaging because of the symptoms that they present with.
And so, and if you're not trying to get pregnant or you're not having fertility issues necessarily, is there, it's important to communicate to your doctor if you do see increased hair growth like on your face and you have a weight gain and things of that nature to maybe signal getting further testing for PCOS.
That's correct. And oftentimes what you'll see in our gynecologic visits, we're taking that history as you walk in the door. So our little lights are going up when I hear those symptoms. And I say, okay, well, when have we had a sonogram? Have we ever? And usually that's a trigger for us to go ahead and do the sonogram.
And I think it's so important because those symptoms you wouldn't necessarily take with you to an OBGYN appointment, right? Like, I mean, if you have hair on your face, you might go to a dermatologist, right? You wouldn't necessarily think, oh, let me go and tell my OBGYN. So it sounds like the more information, the better when you're seeing your doctor.
Absolutely, absolutely. You know, many say we only have a limited amount of time. But in that time period, we have to ask a good number of questions to really get to the bottom of a diagnosis with the patient. So you'll find us asking multiple questions. Sometimes people think, but we really want to know, are you growing hair? What are you doing? And do you have acne? Because acne also is very predominant in some of our PCOS patients. So, you know, we're looking for all of those signs. So we're trying to see the full picture of the individual.
That's fantastic. Thank you. Denise, I'm going to move over to you.
Okay.
Let me ask you a question. 15 years ago, did you think you'd find yourself talking about menopause?
Wait, 5 years ago, I wasn't talking about menopause. So definitely 15 years ago, I wasn't talking about menopause. But
what was your journey?
I mean, so my journey is I think like a lot of women and a lot of women coming up, which is that it catches you off guard. And it catches you off guard a lot of times because we still have our periods. And as long as we still have our periods, you know, we think everything is going fine. And then all of a sudden you have, in my case, you have a hot flash, and the hot flash was pretty severe. And so that was when I finally, you know, recognized that, I wasn't menopause, but I was something. I mean, I didn't even know, you know, perimenopause at the time. Maybe I've heard it, but I think what happens is, you know, menopause equals age equals old. And so women who are younger, I would definitely say women in their mid 30s into late 40s are resistant to wanting to hear anything about menopause because of the equation that it has with being old, and old means disregarded. Right? Old means you're not relevant. Old means you have nothing else to offer. And so a lot of times younger women aren't listening, can't listen. I mean, you know, I have my friends who are 60 saying, oh girl, wait till you get 60. And I'm like, I used to be resistant, like, I'm not there yet, so I don't want to hear it. And now I'm like, well, tell me, you know, what does that mean? You know,
what's the secret?
Right? So I think that, you know, what happened to me is I had the experience. It led me to producing a product for women called Hot Flash Tea. That led me to being able to go around the country and speak to women all over about, you know, they just became receptive and started talking to me. And I kept hearing sort of what I call three consistent things. First, they felt that they wished that they were better prepared for the changes that were starting to happen to their body. Two, they were confused, like I just said, about all the words, you know, perimenopause, menopause, bioidenticals, HRT, you know. And then third, they wondered really, because they weren't sharing things with other people, if anybody else shared their issues. And what I find is that unfortunately, more and more women, and even young women now, are seeing themselves as a diagnosis, a problem or something to be solved. that women's health is so much more than, to me, medical intervention. I mean, if we are just not understanding women and girls, sort of cultural context, our misconceptions, our self-imagery, our life stressors, our simple individuality, as a part of the medical presentation, then we're missing what the entire diagnosis is. And so Dr. McDonald talked about PCOS. PCOS women can go 5 to 10 years misdiagnosed on that, especially if they're going to a general practitioner, which a lot of women go to general practitioners because honestly, they're not goo gobs of gynecologists. You are fortunate and blessed to be able to go to a gynecologist. And so women tend to, suffer really long with PCOS. And as you heard, it has so many different symptoms, which is one of the reasons why it's hard to actually diagnose, right? But we have to start to effectuate passion when it comes to women's care of all ages. I mean, we need to look at and address the woman, not in her part, so that is a part, but in her sum. And we just don't do that in the medical community. We find it more in naturopath communities or someone who's a functional doctor. But in the traditional medical sense, not so much. They're a little behind and sort of embracing a thinking that allows them to go outside of the prescriptive way of solving women's health. And so, I just feel like that led me to, sort of creating a whole event all day for women to learn as much as they can about the variety and really most of the different symptoms that women tend to have, right? So the typical symptoms we kind of know: hot flashes, night sweats, forgetfulness, irregular periods, insomnia, belly flat, low libido. But the ones that we don't know so much that catch women off guard is something called like itchy butt, or really tender boobs, right? As an older, don't think that your boobs should be tender.
We have to go back. What's an itchy butt?
Yeah, I want to hear more about that.
So what itchy?
I have a different name for it, but you tell us what that name.
Literally, it's just when your butt itches, like kind of like when you get something that makes you just keep scratching and you can't stop scratching.
Wow.
Yes, so those are the
Could well be associated with a complication or some type of diagnosis. So we would.
Yeah. But these things start to manifest during this time. Even dry mouth, excess bacteria in your mouth, which means that you have to brush your teeth night and day. You have to floss. A lot of dentists don't talk to their patients as they get older, that they know they see this, but they don't talk to them about what they need to do from a hygiene standpoint, more than what they did before. They may even have to come in for more cleanings because they're building up so much more bacteria in their mouth that they're building up more plaque. Exactly. And then we have so we got the known to the not so known to then what we don't talk about, which is vaginal dryness, or incontinence, right? And so those are the things that I really like talking about, because those are the things that really have relational impact on people's lives. So if I'm having vaginal dryness and I have a husband or a partner and sex is just painful, I start avoiding you. And that avoidance started getting the male in your life to think something's going on. And that creates friction in the relationship where before there wasn't any friction. Or incontinence, if you find that if I laugh or sneeze that I leak, you may not want to get out and go anywhere. And women, Black women in particular, when I did this study, I found that Black women in particular, that this is their challenge: vaginal dryness and incontinence. And yet they find that in terms of the medical community helping them, only 5% of them are getting treatment, where 60% of them are experiencing this.
Wow. Dr. Gail, do you have anything you would like to chime in with that?
Absolutely, because what you're saying is so true, Denise. I can tell you that I have so many patients who have a difficult time discussing these items, and you're trying to peel it out of them, and it's really a challenge. And we are so open to it. We're ready for it, and we're able to kind of, direct them in the right way. There are definitely treatments that we have that can do that. I got the pleasure of participating in your Wise Paws conference on Saturday. Incredible. The number of women and providers that came out for that was incredible. And it has to be offered more broadly because everyone needs to see that. It was incredible. But menopause was the key of the conversation. And there are many women that are having these vaginal issues, that are having issues with sexual intercourse and issues with feeling as though their libido is non-existent. And there are multiple care plans that we can create for those women, whether you do it with an allopath like myself, or you choose to do it with I guess you would say a naturopath, and you have a choice. They're out there, and we need to make women aware of that.
I love that. I remember in the 4th grade, it was right before all the girls would be separated and the boys, I don't know what the boys did.
Yes.
I'm still not clear on what they did. But we saw a whole video. We got a little package of a pad, and we got, we were taught what our ovaries did and all of our, our system and what was to come, right? And it seems like there's a void in that as we grow, because there are changes that come with every step of the way. And there's so much shame. There's shame when you get your period, right? Like, when they gave us the little bags, don't tell anybody. We have Aunt Flo. We don't even use the correct terminology because it's shrouded in shame. And so then all of a sudden, as you get older and the period stops, there's another level of shame. So the thing that you kind of hated, for 30 years, now have gone away, and you're like, wait, come back.
So we have to change the dialogue. We have to change the dialogue. Families need to be talking about this, mothers to their daughters, and just, allowing them to feel great and comfortable with the thought that their body's changing. There's changes that the mom has experience that the daughter's going to experience in the future, and she's got to realize that this is normal, and that will allow her to go out and seek help, because if you can't talk about it, you're definitely not going to go out and seek assistance with it.
I think it's so important. About 10 or 15 years ago, when I was in Los Angeles, they did a study and they found that Black women weren't breastfeeding, right? And they did some research of why that was the case. But a large part of why Black women weren't subscribing to breastfeeding is that they didn't have the community. Their mothers weren't breastfeeders, so they didn't have anybody to talk to get that advice, and they ended up giving up, quote unquote. But it's the same thing. If moms aren't talking to their daughters, like, hey, as you age, this might happen. This is what happened to me. Don't be surprised. Don't be scared. I remember the first time I got cramps, my mom was like, we need to send you to the doctor. I've never had that before. There's something wrong with you. And then the doctor's like, no, that's common. But
I
go ahead.
I'm sorry. I'm 71. So my mom, when I was a kid, and we did that session where the girls went in one room and the boys went in the other. I remember coming home and showing my mother the pamphlet, and she said, she looked at it and put it in a drawer, and it was like, okay, never talk about this again. So that shame is generational, and it's been passed on and passed on and passed on. One of the things we are doing at the Black Women's Health Imperative is starting a positive period campaign. So I'll make sure you guys all get information about it, because we really want, like you said, we want the conversation to change, and for women and young girls not to feel ashamed of who they naturally are. And also there's such period insecurity, so one of the things we did recently in Atlanta, instead of giving care packets with food in the food drive, we gave out sanitary napkins and tampons. Because if folks are getting laid off work and not having, worrying about their income and making different kinds of choices, and you got 2 or 3 girls in the house that are having periods, that can become a challenge. So yeah, I think I agree with you. The conversation has got to change.
Yeah, yeah.
That's really good advice. Angela, I was going to go back to you and just hearing, from Dr. Gail and Denise, and knowing that with menopause can come, some weight gain. How are you all approaching, working in, diabetes prevention with women who are over 50? What does that look like when, losing weight can be a challenge?
So, initially we were not formally addressing it because, this is the National Diabetes Program and the curriculum says you cover A, B, C, and D. And one of the things we're partnering with AARP on is pilot testing, doing the program through our app, so a virtual program. And we decided to culturally tailor some of the material in the curriculum. And one of the modules that we're adding, awaiting CDC approval, is a module called Aging Like Fine Wine and managing weight goals during midlife. And we added it because it comes up in the classroom. The women raise it and they start talking about what the challenge is to lose weight. So we created the module so we could just formally open up the conversation and help women understand how those hormones, those changes really affect their weight loss or their weight gain. And we think that makes a big difference for them because that same shame about, the period and the menopause, that same shame is carried into, like you said, the belly getting a little fuller and the maybe itchy butt or whatever, the leaky, when you laugh, you leak, those kinds of things. I love it now that they have at least commercials about these things, but we just are trying to open up the conversation more and at the same time helping to increase the awareness for women about being okay with asking your doctor questions and sharing information with your doctor about what's really going on with you when it comes to perimenopause or menopause. A lot of women still don't realize there's that perimenopause phase. They think that you go straight, like when you get 60, you're going to go into menopause. I never had hot flashes, So I think part of the conversation also has to be that it can look different in each of us. Some of it, I had night sweats, but they weren't to the extreme of what some of my friends had. So I think the conversation just has to continue. We have to continue to encourage women not to feel ashamed, not to be afraid to ask the questions, not to be afraid to disclose what's going on, and to know that just because your symptoms are not the same as your girlfriend's doesn't mean there's something wrong. It means that those are your symptoms and talk to the doctor about them.
And that's valid. That's good. Dr. Gail, is there a protocol that can be put together to address the hormone shift?
There actually are management plans that we've created. One of the big things that we've always dealt with, because when I was training, we gave estrogen to everybody. Everybody got an estrogen. You're coming in, you're over that age of 55, you're moving into menopause. Oh, okay, you need estrogen. But in 2002, that WHI started a study that they planned to do for 15 years. And that study was looking at combination hormones and how they would affect people who were on the hormone. So they had a huge group. I mean, it was one of the largest studies that we've had in the nation. And it was over like 160,000 people. And they found out, and they had to cut the study short, that the estrogen combination was actually causing some serious problems for a lot of the patients. So, people were getting heart disease. They were having increased risk for breast cancer. They had issues with clotting, venous thromboembolism is what we would call that. They even had issues of stroke. So they saw that it helped them with fractures because estrogen, of course, works very well to strengthen bone. It also even prevented colorectal cancer, but the risk outweighed the benefits in that situation. So they had to stop recommending that we prescribe hormones. So what did we do? We tried to figure out what's next. We started using alternatives. We started using SSRIs. We started using different types of antihypertensives that actually worked with some of the symptoms of menopause, like hot flashes, some of the brain fog and weight gain. We would actually treat symptoms. We were able to get approvals for vaginal dryness issues because the vaginal suppositories that we're using did not get fully absorbed in the system, and that was a positive. So patients who had severe vaginal dryness, it was changing their quality of life. Those were the ones that would opt for that, and they loved it. I mean, they're still using it today. But now also we've introduced the bioidenticals, and the bioidenticals, you know, traditional came from horse urine. That's exactly how we contrived them. We actually got the synthetic hormones or horse urine, or hormones from horse urine. Now that we have bioidenticals, they're coming from plants. And many people feel a lot more comfortable with those items, and we can be used in women and men. They can provide the estrogen, the progesterone, the testosterone hormones that people need, and they're actually benefiting from them now. So we have a lot more providers, not everybody, because a lot of us allopaths are behind the times and we're not really doing that. But there are many a provider who are planning for bioidenticals with their patients and discussing the option.
Is there, let me ask you a quick question. It's a question that we have in the chat. Are there gynecologists that specialize in women who are over 50? You know, one of the questions we're getting is that she has felt like there's preferential treatment with the OB, you know,
Yeah.
and you know, birthing babies versus really treating gynecology and women as they age.
And there absolutely are. What we could probably do is be able to share a link to one of the menopausal societies, and they could give and share with us some of the providers in their region. So we have to look at zip codes and be able to isolate those folks.
That'd be great. Yeah, no, that's great. I didn't even know there was a menopausal society. So
Oh,
that,
yeah.
that is Googleable, everyone. They can Google that. I want to shift gears just a little bit, just because it's so prominent in the Black community with women fibroids. And so, you know, can you share a little bit about that? And as you know, I feel like there's a huge cadre of folks that are in my sphere that aren't menopausal, and they dealing with fibroids, whether they've had kids or haven't had kids. And then what happens as you age with the fibroids? Do they go away?
Okay, so fibroids are a huge topic. So, I'm going to make it short, but I'm going to make it concise so that everyone understands them. But I mean, fibroids actually are the #1 benign mass that can grow in a woman's body. And they are smooth muscle masses that can literally take up space, take up residence in the uterus, outside the uterus, some attached to ovaries, and can really disrupt the reproductive chain. What we tend to find is that if a fibroid is implanted in the lining of the uterus, those can be the most troublesome because they can lead to excessive bleeding. Sometimes it can be an aesthetic issue when the fibroids are outside the uterus and they start growing, and those, you know, actually grow because of blood supply and because of the presence of estrogen. So our ladies who are in the reproductive age range, these are the ladies are really more concerned about their fibroids, because many of us have fibroids and never even know it. You know, you just grow up with those fibroids. They kind of are like, you can give them names and they can sit there all your life and never trouble you. But yet there's some women who have a lot of issues with their fibroids, and they're dealing with bleeding issues. They're dealing with distension in the abdomen and sometimes pain, especially when they start to break down. So what we do is we, again, do imaging. We try to see what we can see, especially when we have a patient who comes in with the symptomatology that suggests that they may have them. And we look to see what their plans are. Do they have plans for conception? Do they have plans just now, or are they the age that they're moving into menopause? You know, how valuable will therapy be for them? Is quality of life affected? Because if your quality of life is affected, then we want to treat some of those symptoms and improve your quality of life. So deciding what we're going to do with a fibroid is really based on the individual patient. If they're markedly large, you know, when they start to really get big, then we probably would counsel about removal, and we give options of how to do that. But for the majority of our patients, we watch them and we see if it's necessary to take action. Many patients who are dealing with bleeding, we offer them hormones in the form of oral contraceptive pills. Some patients are having exceptionally high bleeding levels, and we have to do some IV managements, or we have some oral methods that are in the market now that actually work very effectively. So these are the things that you would talk to your provider about, what applies to you. But the key with fibroids is that when you're trying to get pregnant, and if they're taking up space in that uterus, then they could conflict with the pregnancy. And so these are the ones that we want to remove prior to pregnancy. And those are the patients that, don't get discouraged. Come on in, let's see what we can do. We have studies to assess where they are, how we can approach them, and how to remove them.
And so, and as you age, do they shrink? Post, your fertility years.
Yeah, I'll tell you, as you age and your estrogen levels start to decrease, you're going to find that even those fibroids start to decrease in size. Yeah, they start to get smaller.
That's a win. That's a win. Find the ways where we can. So I'm going to start with Denise, but I'm going to ask everyone this question. I think it's so important. What is Denise and I were having a conversation about a wellness team. So what is a wellness team to you, Denise? Who's involved in your team of wellness folks, and how do they support your health and well-being?
So my team is what I call mind, body, and soul. So the body part is my traditional doctor, my naturopath doctor, and my chiropractor. And my soul team is my yoga instructor, is also a breathing person that I go to, and also a person who does energy. So a lot of times we have energy, other people's energy, negative energy from the environment that sort of, kind of surrounds us. And we need to actually have that released from around us. Sometimes we talk about a person who always have bad luck, right? You're like, oh my God, here that person comes and something's always happening to them. And so you wonder what's the energy that would bring, that attracts or magnetizes that level of negative energy, right? And so it could be somebody's old karma that's a part of them that hasn't been released off of them. And then in mind, it's meditating and also getting massages. And so that's sort of the group that I call sort of my wellness team. And there's individuals that are all part of supporting that for me.
That's great. And so, Angela, do you have a wellness team, and who's in your team?
Well, similar to her, I do yoga. My doctor, of course, but also my daughters. I have adult daughters, and one of them is a physician assistant, and one of them is a nutrition. And oftentimes, between the two of them, that's a lot of where I have my conversations about wellness and health, and even challenges I'm having or questions I'm having. And my daughter will say, well, I think so-and-so and so-and-so, but give Dr. So-and-so a call, because she's not my formal physician, although she's in the same practice. But I think, and my friends, because at my age, I think we are all looking to be supported at this age in our lives by people who also are at this stage in their lives, because some of the issues are just different. And so I would include my girlfriends in that as well.
I love that. And Dr. Gail, what does your bench look like for your wellness team?
Yes. So I love this. I've never actually thought of this as my network of wellness team, but I have my own providers, my dermatologist, my gynecologist, my primary care provider. In terms of, when you think about mental health, I have my network of girlfriends that I can have cathartic sessions, wine, and I individuals that helped me through, the academics of life, the colleagues that helped me with my career, they're all part of my wellness team. So when I'm dealing with an issue and I need to decompress, I kind of go through that little file in my brain and figure out who I'm going to call. And they're all there for me. Of course, my family, who I decompress with on a regular basis. So it's a full network. I have a full network with them.
I love that. I love that. One thing that has been circulating, especially in times during COVID-19, is stress. And it's something that Black women bear at great degrees because we're usually lifting up families, small communities, if you will. So and stress impacts so much, right? So if you're stressed out and you're trying to lose weight, you don't want an apple, you want an apple pie, right? Like, and there's a reason behind that, right? Like, Apple's not going to get it. And so what are some, like, I heard some people do yoga, some people are meditating, but for the person that is under chronic stress, which is a real thing, what's one tip each of you would give that person that's very tangible that they can start doing in a small way with a great benefit to dispel some of the stress?
Movement. I would start with movement. Walking, just going for walks, enjoying nature. Let that be your time. You protect that time and be able to enjoy what's around you in your community. If you don't like your community, meaning that you don't want to walk, it's too stressful, then you find a park or somewhere you can go where you can actually move and enjoy nature.
I like that. Angela, Denise?
I would say doing breathing. Breathing from your belly, and having it rise all the way up to your chest, all the way up to your head, and saying to yourself, perfect health and wellness, and then extracting that air out. And trying to do that, if you could do it 10 times, it's really great. But what happens is, whatever you're stressing about, when you focus on your breathing, you shift your thinking. And so you stop actually thinking about the thing that's stressing you out because you're focusing on the breathing and getting your breath to come from your belly, which a lot of times we get our breath from our chest, which is, like not really the way to breathe. If we do that and get it all the way, and it takes time, get it all the way up to here, it really helps to free up and change how your brain cells are starting to function. And if you were tense in your head, that will start to go away. And then just saying a little affirmation, perfect health and wellness, right? Perfect health and wellness to yourself. Your body hears that, and the body will begin to start believing in that, right? So, what we tell ourselves really actually manifests. And that's another thing that we don't talk enough about, is how we talk to ourselves. When we talk to ourselves out loud, when we say, oh, look at my fat butt getting in this car, right? We say that to other people, but sometimes we'll say that internally too. So both of that dialogue, we need to change.
I like that. Denise, you were bringing up some new things. And so I encourage people to go to YouTube and maybe finding some sort of video for breathing and breathing exercises. It doesn't necessarily have to be cost associated, but that's something that we have access to. Just as we can walk, for 20 to 30 minutes, we can breathe for, even if it's 5 minutes, that could really help. Angela, do you have a prescription for?
Sure. I would say don't be afraid to ask for support. And ask for support from that wellness team that we just talked about, but also seeking therapy. I've gone to therapy several times throughout my life, and you don't have to wait until there's this major crisis and you're falling apart to seek therapy. Sometimes you just need somebody who's totally impartial, doesn't know who you are, may not know your secrets at this point, and won't be judgmental, but somebody that will certainly understand and help you sort of sort some things out. So folks should never hesitate to just say that I'm feeling stressed out and reach out for help through a therapist if needed. And also I would say just pay attention to what triggers you. you know, and if you can, you know, just change the way you respond to those triggers when you can. But again, even in doing that, you may need to reach out for support from somebody to help you do that.
I love the idea to bring up therapy, because I think that's another cloud of shame, you know, in our community of not being, but it can be, you know, the best prescription. And changing your mind, you can change other things, your health and well-being, you know, losing weight, like all of these things that can affect us physically. If we change our mental capacity, can help support our physical wellness as well. I love that idea. So we're nearing the end. We have about 10 minutes, and you all know that I'm going to ask you. We've talked about a lot. There's a lot of information. If there are just two things that you would want our viewers to know, what are those two things that they could walk away with? And my hope and the intention is that out of the two, everybody will pick one from each of you, and share it with friends and family, so that we can create an environment of health and well-being. So Angela, you want to start?
Sure. I would say the number one thing would be just try to do the right thing most of the time. You know, it's so hard to change behaviors, but just try to do the best thing most of the time, and don't beat yourself up if you aren't doing it. If you're not eating the perfect meal every day, if you're not physically active every day, give yourself credit, pat yourself on the back when you take small steps.
Grace, I love that. Dr. Gail?
I would say that your providers, even during this COVID time, we are available. Our doors are open, whether we're doing telemedicine or whether we're letting you right in the door. Visit your provider. And when you come to us, come with your questions and don't feel any shame in bringing them to us, because we're there to help. And that's what we want to do. And one of the worst things is to walk out of that office and say, darn, I didn't ask this question. So come with your questions, bring them on, and come see us.
That's good. I think it's worthy to note that a lot of folks are being afraid of going to their medical care providers, and I fear that they're going to wait and until it's an emergency, right? For things that could have been prevented. So, do you have any recommendations of keeping yourself safe when you're visiting your care provider?
Absolutely. So all of us are office setting, and one of the things that we are doing is ensuring that the rooms are cleaned, ensuring that everyone's wearing masks, and ensuring that we're checking temperatures as well. So we have an opportunity to check on whether or not you are doing, you know, the right thing as you come in, and we're making sure our staffs are doing the right thing inside the office as well.
I love that. Dr. Gail, we did have one question I wanted to point out that was in the chat. At what age do you stop getting pap smears?
Oh, okay. Well, it matters on your history, but right now that age is 65.
Okay.
So we do PAPs, and we have all different variations of how we're doing PAPs these days. But for my high-risk patients, I like to do a pap smear and an HPV testing, which is the high-risk type of HPV. And we do that all through your reproductive years, either 3 to 5 years apart, based on the type of study we're doing. And by the age of 65, as long as you haven't had any precancerous changes on that cervix within 10 years, then we're stopping at 65. If by chance you had some changes that approach 65, that may prolong you. So you might be that exception that goes beyond 65.
Okay, that's good to know. And it's just always good to know, so you can be your own health advocate to make sure, you know, I think it's a relationship, and it can't be just based upon what the doctor is saying.
Right.
Sometimes you have to advocate for yourself to make sure you're getting the tests that you need.
Right. And to that point, Jennifer, you know, we just want to remind women, if you are seeing a healthcare provider and you are not happy with that healthcare provider, find a new healthcare provider.
Yeah.
And folks sometimes think, well, this doctor he or she's not personable enough, or they don't listen to me. You have a right to change healthcare providers. And I know that comes with some challenges depending on your insurance coverage and all that. but folks should feel okay about doing that if they're able to.
I like that you underscored that. I think,
Yeah.
again, it's a relationship and everybody's not going to be for everyone.
Right.
I've had experiences with doctors because I think I was hyper vigilant, and I was going to a doctor in Koreatown in Los Angeles, and he was outdone because I was like, I need this, I need that, I need that. He didn't like my health advocacy, and he said, do you also want your freckles removed? And I said, point taken.
Okay.
And there's nothing wrong with him. He just
Right.
was not for me.
Exactly.
And so I'm going to another doctor, but I think it's worthy to note. I think it's also worthy to note is, if possible, having a doctor that is culturally competent and that is familiar with your needs. As people of color, our risks are different in some cases. And we need tests that might be, you need to get them at an earlier age and things of that nature. So making sure that someone that is familiar with your culture, I think, is sometimes very helpful when you're looking for a healthcare provider. That's good. I like that.
Yeah.
Denise, do you have a few tips for us as well?
I definitely totally agree. It's one of the things I always tell women, that the doctor that delivered your babies may not necessarily be the doctor for you at, once you hit menopause, to help you, if they definitely haven't been studying up on the aging female body. So first, I'd like to just let women know that menopause is not a disease. It's a normal cycle in a woman's life. It just means that your ability, your fertility has come to an end, right? And that's really all it means. And the fact that it happens to every single woman in the world, so that there's no reason for any of us to feel that we're alone or harboring or not, sharing something with, a couple billion women. And then second, you are in control of your health. Angela talked about just the change you make, not the change a doctor makes, the change you make of 5% and the change that could have on your diabetes. That is you being in control of your health. And we tend to believe we're not in control of our health. And I'm not really sure where that comes from, but you are in control of your health. And there's also that there are a lot of practitioners that can help you. Dr. McDonald mentioned the Menopause Society for women who want someone that specializes in aging women and their health issues. Also, you can go to wisepause.com. We list a ton of doctors on there as well. But you are in control. It's you make the choices, you make the decision, and there's nothing wrong with you. I think that's the other thing that we need to say to women over and over again. There is nothing wrong with you. It's how society has been treating us. And we talked a little bit about, they've been doing that since before we've had our period to having our period, right? So we're in control, ladies.
I love it. Are there any other closing thoughts before we close? Well, I just wanted to thank you all. Thank you for this great conversation. Thank you for being honest and vulnerable and informative and fun. I think we need to have more conversations like this. AARP, this is one of our foundation is really health wellness, financial wellness. We know that health is wealth. And I think one of the number one things we want to do as we do get older and celebrate aging is to be healthy. And that comes in a myriad of different ways. So I appreciate all of you joining us today. We appreciate AARP extends great and deep appreciation for the Rolling Out team and family for the past 15 weeks. We've partnered, we have talked about all sorts of different health components as it's related to COVID, as it's related to music and mental health. We've done so much, and you've been a great community for us, and sharing the messaging to the Black community. And so we'd like to send a special thank you to Munson Steed, to Portia, and to Ashley. And we wish you good health and wellness as we're dealing with all of this. So take good care and have a great night. Bye-bye.